Welcome back to The Explainer. So today we're diving straight into the complex, sometimes intimidating world of antifungal pharmacology. I know looking at a giant list of drug names can feel pretty overwhelming, right? But hey, that's exactly why we're here. We're going to transform that dense list into a structured, easily deployable arsenal of medical knowledge. We'll break down exactly how these drugs work, when to use them, and most importantly, how to keep your patients safe while they're battling these really stubborn infections. Let's get into it.
Here's our tactical map for today. We'll meet the Antifungal Arsenal, cover Amphotericin B, the azoles, the echinocandins, surface and topical threats, and finally, our general rules of engagement.
Section 1. Meet the Antifungal Arsenal, understanding the fungal threat.
Okay, so before we draw our weapons, we really have to understand the enemy here. You might be wondering, why can't we just throw standard antibiotics at them? Well, fungi are eukaryotic. They're actually much closer to human cells than bacteria are, which makes them super tricky to target without accidentally hurting the patient in the process. But they do have an Achilles heel. Actually, they have two. They rely heavily on two distinct structural components that our cells just don't use in the same way: ergosterol and beta-glucan. See, human cell membranes use cholesterol, but fungi, they use ergosterol. And human cells completely lack a beta-glucan cell wall, none at all. So this gives us two massive vulnerabilities to exploit. In fact, literally every single drug we're going to discuss today is designed to attack one of these two exact structures.
Section 2. Amphotericin B, targeting severe systemic infections. All right, picture a patient with a life-threatening, severe systemic infection. We're talking a massive aspergillus or cryptococcus infection. In these high-stakes scenarios, we escalate straight to our absolute heaviest artillery, amphotericin B. This is a crazy powerful fungicidal agent. It literally binds to that ergosterol we just talked about, tearing physical pores right into the fungal membrane, causing all its cellular contents to just leak right out. But because it's so powerful, it brings some immense collateral damage during the IV infusion. You're definitely going to hear the infamous phrase "shake and bake" tossed around in clinical settings. And that's because patients routinely experience this massive fever, severe chills, and intense rigors. And honestly, the side effects don't stop there. There are extremely serious risks of nephrotoxicity. This drug is notoriously brutal on the kidneys, which can in turn lead to really dangerous electrolyte imbalances, specifically hypokalemia and hypomagnesemia, plus potential anemia.
So because of that immense collateral damage, you've got some critical tactical maneuvers to pull off before you even think about hanging that IV. First things first, you absolutely must premedicate your patient. We're talking acetaminophen to fight the fever, diphenhydramine for the hypersensitivity, and hydrocortisone to calm down that massive inflammatory response. Next up, you want to administer it via a really slow IV infusion. Doing that helps mitigate that terrible shake and bake effect. And finally, you have to continuously monitor their renal function. You're keeping a hawk's eye on daily weights, INOs, BUN, and creatinine, not to mention their electrolytes and complete blood count. Now, side note, liposomal formulations are available nowadays and they're slightly less toxic, but don't let your guard down. The clinical vigilance required remains exactly the same.
Section 3. Azoles, the versatile fighters.
Moving on to the azoles. This is a super versatile middle ground class that also targets that fungal membrane by disrupting ergosterol. But they come with an entirely different risk profile and a much wider variety of clinical applications. The real key here, knowing exactly which specific azole to deploy for the fight in front of you. Just take a look at this breakdown. Fluconazole, for instance, is absolutely fantastic for oral and systemic candida or cryptococcus, and that's largely because it has great oral bioavailability and way fewer complex drug interactions. But let's say you're dealing with aspergillus. Well, you'll need to step it up to itraconazole or voriconazole. Voriconazole is excellent for that, but you've got to watch out for its unique collateral damage. It frequently causes visual disturbances in patients. Kind of wild, right? Finally, we have ketoconazole. That's an older generation drug, and honestly, we try to avoid it for systemic use whenever possible because it's highly hepatotoxic and just notorious for causing major drug interactions.
And that brings us to the class-wide risks for azoles. Remember the heavy renal toxicity of amphotericin B? Well, scratch that here, because your main nursing priorities shift almost entirely to the liver. Hepatotoxicity is a huge risk across the entire azole class. You're also going to want to watch out for GI upset and cardiac issues, specifically QT prolongation. But honestly, perhaps the single most challenging aspect of using azoles is navigating their really complex drug interactions. Many of them are potent CYP450 enzyme inhibitors. That means they can dangerously elevate the levels of other medications your patient might be taking, like statins or warfarin, right there in their bloodstream. So always double-check those med lists.
Section 4. Echinocandins, cell wall blockers. Next up, we have the echinocandins. This class includes caspofungin and mycofungin, and they act as highly effective IV-only alternatives for those invasive Candida and Aspergillus infections. They're especially great when a patient simply cannot tolerate the heavy artillery of amphotericin B. Now, they also represent a really fascinating core mechanism divide in our arsenal. Think about it. We've spent this entire time talking about the cell membrane and ergosterol, right? Well, while amphotericin B and the azoles are busy poking holes in or disrupting that membrane, the echinocandins take a completely different route. They target the fungal cell wall by inhibiting the synthesis of beta-glucan. So instead of just deflating the cell, they literally shatter its structural integrity.
So why is that shift from ergosterol to beta-glucan so incredibly important for the patient? It's simple. Because human cells lack beta-glucan entirely. We just don't have cell walls. And because of that amazing biological difference, these drugs are remarkably well tolerated compared to the rest of the antifungal arsenal. Your clinical monitoring becomes so much simpler here. Generally, you really only need to watch out for mild infusion reactions and maybe a slight bump in liver enzymes. It's just a highly targeted, super elegant pharmacological solution.
Section 5, Surface Threats and Topicals, De-escalating to Localized Fungi. Okay, time to de-escalate our tactics a bit. Let's be real, not every fungal infection is a massive, life-threatening emergency in the ICU. A lot of times you're just going to be managing localized, surface-level threats. Things like oral thrush, ringworm, or those really stubborn nail infections. For oral candidiasis, which we commonly call thrush, nystatin is our absolute go-to. Now, what makes nystatin so perfect for this localized GI and oral threat? It actually works really similarly to amphotericin B. But here's the kicker. It is very poorly absorbed by the human body. That means it can safely coat the mouth and digestive tract without causing all that systemic toxicity. Just make sure your patient strictly follows the classic swish and swallow command. They really need to coat their mouth thoroughly to eradicate those local fungi right there, before swallowing the medication to treat the rest of the GI tract.
When it comes to those stubborn skin and nail dermatophytes, your go-to arsenal includes terbinafine and griseofulvin. Terbinafine is highly effective for things like nail fungus, but heads up, you definitely have to monitor the patient's liver carefully for hepatotoxicity. On the flip side, we have griseofulvin, which is often used for teeny infections like ringworm. Now, the key clinical pearl you need to remember here is that griseofulvin treatment takes immense patient patience. We are talking weeks to months here. Plus, it strictly requires the patient to take it with a high-fat meal just so it can properly absorb into the bloodstream. I love this one because it's a great example of how simple patient education, just tweaking their diet a little bit, can completely dictate the success of the drug.
Section 6, General Rules of Engagement, Overarching Nursing Principles. All right, let's tie this entire arsenal together. Whether you're dropping the heavy artillery or just managing a localized skin infection, these rapid-fire principles are your absolute clinical bedrock. First up, safeguard the liver. Honestly, with the exception of amphotericin B's massive kidney risks, almost all systemic antifungals carry a significant hepatotoxicity risk. Second, get those culture confirmations early. Do this before you start throwing these heavy drugs around. Third, you must relentlessly remind your patients that defeating a fungus is a long marathon. It's definitely not a sprint. Because fungi are eukaryotic, they are incredibly stubborn. Treatment courses are notoriously long, which makes strict medication adherence absolutely vital. And finally, you have to educate your patients to immediately report any signs of liver issues. Tell them to watch out for things like yellowing of the skin or eyes.
Which leaves us with this final, pretty pressing thought. We've seen how effectively we can target ergosterol and beta-glucan today, right? But fungi are ancient, highly adaptable survivors. As we master this current arsenal, the evolutionary arms race just continues in the background. So what does this all mean? How will medical science adapt to defeat tomorrow's drug-resistant superfungi? It's a massive question that researchers and clinicians alike are going to have to answer in the years to come. Thanks so much for joining me on this explainer. Keep learning, stay curious, and I'll catch you on the next one.